Hey guys, so let us continue this series of previous year question with topic discussion. And this is the second question. The question reads as a patient presents with irregular pulse of 120 per minute and a pulse deficit of 20. So which of the following would be the JVP finding? First of all, the patient is having irregular pulse. So we have two TDs. One is atrial fibrillation, or the patient would be having multiple PVCs, that is premature ventricular contractions or ventricular ectopics. So now pulse deficit will help us in differentiating between atrial fibrillation and PVCs. If pulse deficit is less than 10, it points towards multiple ventricular ectopics, and if pulse deficit is more than 10, then it points towards atrial fibrillation. So definitely the patient is having atrial fibrillation since the pulse deficit is 20. Now, what is the JVP finding in in atrial fibrillation? Since atrial fibrillation means the atrium is not contracting, it is just fibrillating. Okay, so the JVP finding would be that A wave in JVP is because of atrial contraction. So A wave would be absent in JVP. That is option B. Absent P wave. So P wave is not there in JVP. P wave is there in ECG, and P wave is because of atrial depolarization. So in atrial fibrillation, P wave is not there in ECG. Okay. So if the question says that what would be the finding in ECG, then the answer would be absent P wave. Now the question is asking for what is the JVP finding, then answer is absent A wave. Clear? Now we have two things to discuss in this question. The question covered two topics. One is atrial fibrillation, another one is JVP. So we'll discuss both of them. First of all, let us discuss JVP. So what is a normal JVP? The normal waves in JVP are A wave, C, X, V, Y. Okay. A wave, then we have C notch, then we have X descent, V wave, and a Y descent. In a normal JVP, A wave is more than V, and X descent is steeper than Y descent. This is a normal JVP. Okay. In normal JVP, A wave is because of atrial contraction. That is RA contraction. Then RA start relaxing, so the pressure starts dropping. Okay, pressure is starting dropping. C wave is because of the closure of tricuspid valve, which is like indenting into the RA. Okay, so it is because of tricuspid valve pushing into the RA. Then we have V wave. V wave is because of the filling of atria. So RA started filling again from IVC and SVC, leading to a V wave because of the increase in the pressure in RA. And Y descent is because of going of RA blood into the RV. At this point, there is opening of tricuspid valve and RA blood started going into the RV, leading to a Y descent. So this is a normal JVP. Now, what are the abnormal things in the JVP? Abnormal things in JVP can be Canon A waves, tall A waves, absent A waves. Clear? So absent A wave, as we have discussed, is seen in atrial fibrillation. Tall A wave and Canon A wave. So what is the difference between tall A wave and Canon A wave? Canon A waves mean that A waves are very tall, and they are mostly because of the AV dissociation, that is atria is contracting against closed tricuspid wall. Okay, so like this is a tall A wave and this is a Canon A wave. Clear? So tall A wave is because of tricuspid stenosis or PEH. That is, the pressures are high. So atria have to contract against a high pressure, but definitely there is a pathway. But Canon A waves are because of AV dissociation, that is atria is contracting against a closed tricuspid wall. So Canon A wave is seen in conditions of AV dissociation like complete heart block or junctional rhythm or junctional tachycardia. Clear? So these are the abnormalities of A wave. Other than that, We can have JVP abnormalities in constrictive pericarditis and cardiac tamponade. This is a very commonly asked question. What happens in pericardial tamponade is that there is a lot of fluid in the pericardium which is compressing the RV. Okay, so there is no passive filling of RV. So there won't be any Y wave. So in cardiac tamponade, there will be absent Y wave. While what happens in constrictive pericarditis is that there is rapid passive filling of RV till the point जब तक कि RV की wall जाके stiffened pericardium से टकरा नहीं जाती. Okay, so there is rapid RV filling in the passive phase. Okay, so in constrictive pericarditis we have rapid Y descent. Okay, so that is the difference between cardiac tamponade and constrictive pericarditis on the basis of JVP. And this is the most commonly asked question. Clear? Now let us discuss about atrial fibrillation. So what is atrial fibrillation? Atrial fibrillation is, first of all, it is most common sustained arrhythmia. Clear? Patient can be in atrial fibrillation for like 2 months, 3 months, year, or maybe lifetime. Okay, so it is the most common sustained arrhythmia. There are multiple ectopics and arrhythmogenic pathways in RA, जिसकी वजह से वो प्री एक्साइटेशन होता रहता है अलग अलग पार्ट से एंड देयर इज एट्रियल फिब्रिलेशन. इसमें आरए कॉन्ट्रैक्ट नहीं करता है, एलए कॉन्ट्रैक्ट नहीं करता, दे जस्ट फिब्रिलेट. ओके, नाउ व्हाट आर द ईसीजी फाइंडिंग्स? फर्स्ट इज एब्सेंट पी वेव एज आरए इज नॉट कॉन्ट्रैक्टिंग. अनदर वन इज देयर इज irregular RR interval. Clear? As shown in this ECG, you can see that this RR gap and this RR gap and this RR gap all are different. So irregular RR interval. Why this happens is because suppose this is AV node. One impulse comes from here, another one is coming from here, another one is coming from here, one is coming from here. And also AV node is in refractive period at different points of time. Okay, so there is irregular RR interval. Now for atrial fibrillation, we treat like rhythm control, then we have rate control and anticoagulation, oral anticoagulation. Normally in chronic AF, rhythm control is equivalent to rate control, but in acute AF, we generally prefer rhythm control than rate control. Clear? Rhythm control can be by two methods, electrical cardioversion or pharmacological cardioversion. Clear? For pharmacological cardioversion, we have drugs like amiodarone, we have drugs like flecainide, we have drugs like ibutylide. Ibutylide is a class 3 agent, flecainide is 1C, and amiodarone is class 3 agent. For rate controls, we have drugs, AV node blocker drugs, which are ABCD. A is adenosine, but it is very short acting, so we generally don't prefer it. Then we have beta blockers, then we have calcium channel blockers, and digoxin. For oral anticoagulation, we divide the AF in two types. One is valvular, another one is non-valvular AF. For valvular AF, you have to give oral anticoagulation. And preferred oral anticoagulation in valvular AF is warfarin. In non-valvular AF, you have to decide on whether to give anticoagulation or not on the basis of Chad-West score. and here we can give NOx and warfarin both are equivalent. And NOx is very important topic for you guys because it is something which is new and most of the studies are going on NOx. Okay, so we'll discuss about NOx. अगर कोई question आता है तो NOx are new oral anticoagulants which are also known as DOACs, direct oral anticoagulant, which includes dabigatran, apixaban, rivaroxaban, and edoxaban. मोस्ट ऑफ द स्टडीज इन्हीं चारों NOx पे हुई है, इसलिए इन चारों पे ही क्वेश्चन आएगा डेफिनेटली. ओके, ऑल द बेस्ट गाइस, सी यू इन नेक्स्ट क्लास.